Hi, Julia. Okay, guys, we're gonna get started because we have a lot of information to go over. I know there's only two of you guys, but I'm sure that there's some people, like I was telling Shannon, that are just finishing report that may be signing on after their shift. So I have recorded this presentation, so I can send it to you guys as well. I'll send it just to the group if you'd like to go back and reference any information. But we're just going to go over expectations for precepting, fellowship binders, even like some questions that I've gotten, really great questions about central line competency that we've been doing the last couple of years, and kind of some plans moving forward for that. Um, all three of you guys are on night shift, so would love to hear your feedback, love to hear your questions, and really, trying to build the education from here, really for our preceptors, because we want to show you guys the support as well. I'm going to go ahead and share my screen. All right. Are you guys able to see NICU preceptor teams? It's like a big purple.
Yeah.
Thank you. Okay, perfect. So first wanted to just take a minute to say thank you guys so much for your hard work, your dedication. To new team members, we know the ask that we are putting onto you guys for being a preceptor, the amount of people that we onboard, that we train. You guys are truly doing the Lord's work out there. We appreciate all of the feedback that you bring us. We appreciate all the support you give them, and it doesn't go unnoticed, and we really do appreciate all that you're doing. Um, just a quick overview and intro. Preceptor responsibilities is really to stay connected. The preceptor should be present 100% of the time. We're going to talk about TSAM, how, and I feel like we used to have this mentality of like divide and conquer. You take this baby, this will be my baby for the day. Let me know if you need anything. And really why, and I will like first to admit that that's how I used to precept at times, especially when I first started to precept. But there's just a lot of holes in that method that don't really allow us to get to a place with orientees where we can really fulfill the delegation, the workload management, the, really building off of the tiers so that they are always involved in every part of the assignment. Um, Debriefing with your orientee, having moments that, are appropriate times throughout the shift to really talk about their progress, their challenges, barriers, and like how to have those conversations. I know that those sometimes can feel like really tough conversations, but how to make those conversations comfortable. And really immediate escalation of concerns as well to either Jordan, myself, or our educator team, or your nurse leader that's here 24/7. So your unit supervisor who's always on shift. If, for some reason we're not there. Um, this escalation, this immediate escalation really helps us with providing, I know that, 12 to 16 weeks seems like a lot, but that time actually really flies by. So really us being able to implement whatever kind of support that's needed as soon as possible is truly key. So there's a lot of things here, but I'm just going to go over these things in detail of the roles and responsibilities of the NICU preceptor. So 6 kind of objectives here. So the fellowship binder. So if you can see me, this is what the fellowship binder looks like. This is what it will look like for June as well. So it's a binder that I created for orientees to carry around that has all of the essential documents that they need to either complete before the end of orientation, or just to help as a resource for you guys or for orientee and really what they're supposed to be completing, goals they're supposed to be hitting, things like that. So the first thing in that binder is the TSAM objective form. So you guys will see this form in a couple of slides, but I feel like most of you guys are familiar with this form. and that this is the form that I do need turned in because they have a TSAM HealthStream module that is on their to-do list within HealthStream. I need this objective form back to complete that health stream module for them. It really just highlights the TSAM objectives. It's your initials and the date that they completed those objectives. And then your signatures will be needed on the bottom of that form before turning in. And we do also do like a good job of like reminding you guys of this in weekly check-ins, fellowship family emails, things like that. In the fellowship binder is also a TSAM checklist. So this is not something that like needs to be completed, but is more of a navigational tool and resource for you guys. Really, what I did was I took, when TSAM was new to our unit, I took the health stream checklist and I broke it into tiers. That TSAM checklist, or that, I'm sorry, that health stream checklist is very long. But I really wanted for you guys to feel like, I feel like a very common question is like, okay, how do I know that I'm officially out of tier one, out of tier two, and, et cetera. This form really helps you like know like, okay, we've truly checked off all of the things that are required for tier one and we can move on to tier two. But we'll talk about also like expectations of you don't have to complete everything within tier one to move on to a different tier, move on to tier two and tier three. But it just really makes sure that you've again just checked all the boxes of all the skills. There's also an assignment tracker that's in here. This is the orientee's responsibility, but just so that you guys know that this is in the binder. I really only ask to see this if the orientee or you guys come to us and say, I'm really having trouble with time management, or I'm not seeing a lot of acuity. I can look at this assignment tracker and really look at the nitty gritty of like what they're having week to week and what kind of assignments we maybe need to put onto wish lists. So again, this is the orientee's responsibility. They know that it's not something you need to check in on, but something that may come up that I use as a navigational tool if you guys are telling me they need a little bit more support. Biweekly QR codes. So I think most of you guys are aware of this, but my newer preceptors, this may be new. So the biweekly rounding form used to be a paper, hard copy. We've now moved to a QR code just to save on wasting paper, sustainability. Um, so there's now a QR code that is in the back of the binder. You guys will scan that QR code and complete the form together. Kind of jumping down to objective 3 down here, the biweekly QR code form. So you'll scan the code. You guys do have to complete it on the same device, so have to complete it together. So if Shannon is doing her QR code with her orientee, she'll scan the code on either her phone or orientee's phone. The first thing that will pop up is a little disclaimer that this will take it just says this will time lapse at 90 minutes. A lot of people will see that and be like, oh my gosh, does this take 90 minutes to fill out? That's not the case. It just times out after 90 minutes. So you can open the form, start it, and then pause if you guys need to pause and do something. But it will time out after 90 minutes. The form itself and the questions really shouldn't take longer than 5 minutes max for you guys to complete it together. But there will be a section where you'll take the device, put in your scores of where you feel like they are with things within each tier. You'll score them from 1 to 5 of, being needing intense guidance or being independent within certain tiers. Then your orientee will fill out the same questions of their self-assessment of where they feel like they're at. And then there will be a little spot of like wish lists for assignments, goals you'd like to work on in the next couple of weeks, or any additional commentary of progress or challenges that have been going on orientation. Ideally, this QR code is filled in before you have your biweekly check-in, so up to objective 2 here. So your biweekly check-ins are ideally with orientee, preceptor, and mentor. Because we have so many people on orientation, we do have the support of 2 fellowship support team members. So this is Julia Pina and Claire Kaiser, who's now Kerrigan. They will help us with check-ins with those that we do not feel like have any concerns. They're doing great, progressing. If you feel like you have an orientee that you would like to address some concerns, maybe you're seeing some red flags, or even you feel like they're just yellow flags, you're not too concerned yet, but you'd like to meet with a mentor versus a fellowship support team member, please just reach out to Jordan and I and say, hey, I know that we're supposed to be with Julia this week, but I would really like to address some like, progress or goal making with my orientee, and we're happy to add you to our schedule. But Julia and Claire really are there to just help support the large uh, volume of check-ins that we have every week. Um, I feel like most of you guys know this, but we will either schedule your check-in for the end of night shift or during day shift if you're on day shift, depending on your schedule. Just know that there are times where like I will come in at 5:30 to get like a round of check-ins done. So it really is important for, us to try and get that check-in done. I know that there's a lot going on in your shift, but I think that just letting me know sooner rather than later, you guys can always shoot me a text and say, I don't know if I'm going to be able to make it to the check-in, but my orientee can come. We'll figure it out. But just knowing that like we do plan in advance coming in early to see you guys and support you guys, and just want it to, your priority is your patient care, but just want to have it like a part of our plan, and you guys just letting us know what you need, and if you need to reschedule sooner rather than later is always ideal. Um, Always reach out if we can reschedule or if there are any conflicts. There are times, especially with working with Julia and Claire, there are some times where we will schedule check-ins like one week after the other. And if you guys notice that and you're like, hey, we just checked in last week with Julia, like, is there any way we can maybe move this check-in? We may have done that for a reason. We may have, strategically planned the check-in that way, but it also just may have been an oversight. So always feel free to, reach out to us and say, hey, we just checked in. And if it's something that we can move and reschedule, I'm always happy to do that. So always just let us know. Objective 4, TSAM understanding. We're going to go over this in the next couple of slides. But really, like, TSAM is just about building on those tiers, slowly putting on their plate what they can manage and not just dividing and conquering. They're always a part of every assignment, and we'll go into that in a little bit more detail. Feedback, another, objective number 5, escalating to mentors, educators, and NICU leadership, no matter how small, even if you feel like it's only week 2, I feel like they just need to get acclimated. Not really sure if this is a major red flag. I don't want to bother Carly and Jordan with this. You are never bothering us. We want to know all the things, no matter how small, no matter how early. Again, like I said in the first slide, because we only have 12 to 16 weeks with them, really we want to implement support and resources as soon as possible. Feedback in real time and prior to check-ins for mentor awareness. So really just, capitalizing on the moment, have like I just said, that 12 to 16 weeks isn't a lot of time. So really making sure that also if there's feedback that needs to be given, maybe you don't feel totally comfortable giving that feedback, that you're letting us know prior to those check-ins, the concerns or the challenges that you're seeing, so that we can discuss a plan about how to gracefully bring up these concerns in conversation. We don't want to let a biweekly check-in go by and have to reschedule one later in the week or even that next week when we can handle it in that moment and in real time. And we can talk to you guys through those things. Written feedback is always ideal and appreciated. I love when you guys come by the office and fill us in after a shift. I, love to see you guys and hear personally and in real time what you guys are seeing, going through. But I will say that written feedback, especially if it's after a shift, you want to go home, you're tired. You could always, like, I suggest to people, like, creating a note on your phone, jotting down the things that are happening in your shift, and just sending that in an email to us. That is so appreciated and something that we can save and keep record of. So always kind of ideal. Support. So you guys are the welcoming face, the resource for these new team members. You're the one that is again, they're in real time and for the majority of the time. So your feedback and your presence is so valuable. And really who we look to, that like I look to you guys as the experts of what kind of assignments you need. What if we need to make changes, if we need to, put you guys in a different neighborhood for assignments, but also for feedback. Like you guys are the ones that are seeing these things and spending all of these time with these new team members. And we really look to you guys to share with us what's going on and that we are growing safe and thoughtful NICU nurses. So your input is so valuable to us. So I just want you guys to know that. Okay. So what is TSAM? So TSAM stands for a tiered skill acquisition model, and it's based on building concepts from simple to complex. So the idea is that the orientee has their hands in every assignment, even if it's a 3 baby, even if it's the, start of their orientation, even if you guys have critical patients, but they're only taking certain skills within those assignments so that they're having access and they're having more opportunities to practice these skills. Um, the preceptor does everything else that falls outside of the tier that they are currently not practicing in. So, for example, really quick. This is a nice little diagram of the TSAM model, a very quick overview of what orientee and preceptor's responsibilities are within each tier. This model, if you ever just need a quick glance at like, okay, where are we at? What do we need to be working on? This is a nice little model to go to. One of the resources that you can find in their fellowship binder if you ever need to peek at it. Um, but like I was saying, for example, when you start off with your orientees, they are going to be doing vital signs, assessment, cares, and documenting on all of their patients. That is going to be the skills that fall onto their plate for each patient that you guys are in charge of. So even the sick babies, I want you guys going over their vital signs. I want you going over, the assessment with them, going over what a care looks like and the documentation that comes along with it. I don't expect like right off the bat that they're, again, proficient in these things, but that they are having access to practicing these skills within each hands-on care. Um, Other things that go along with it that are big components to NICU are like thermoregulation, our hourly roundings on central lines, CLABSI bundles, VAT bundles, things like that. Correct positioning and handling of baby. So just how to put a baby back developmentally appropriate, positioning baby appropriately. So within that first couple of weeks, those are the only skills that they're practicing. All other things like meds, milk, those are skills that you are handling as the preceptor. That's not in their wheelhouse yet. Once they've accomplished those goals in tier one and you feel like they're doing great, they're managing their vital signs assessment and documenting and cares appropriately, then we move into round our tier two. They don't lose those skills from tier one. Those are still going to be in their like bucket of responsibilities, but then they're going to add skills from tier two. So those are going to be medications, order sets, milk preparation, feeding, and specimens. So now they're starting to do labs. They're starting to do heel sticks, labs off of our central lines for UVCs, UACs, PALs. They're feeding the babies. They're checking the breast milk. They're prepping milk if that's part of your day. They're acknowledging order sets and making sure that you're seeing that not only are they acknowledging orders, but they're implementing them at bedside, feeding titrations, respiratory titrations, that they're acknowledging the orders, but that they're following through and making sure the respiratory therapist has implemented those changes. Medications, that they're practicing their 5 rights, that they're doing med math for you before giving each med, that they know why they're giving the med, they know how much they're giving, right person, right place, right route, right time, right? So doing all of that due diligence of checking in on those things. Okay. And then just to kind of go through the other tiers a little quicker, just to utilize on time, because we can talk about these more in check-ins if you guys have any questions. But then moving on to tier three, this is going to be care planning. So making sure they're a part of trio rounds, with the doctor, with the parents, with the care team, that they're understanding, reading provider notes. They're knowing, order changes are going in, but why are we making those order set changes? High risk procedures, like maybe going down for field trips, PICC line placements, septic workups, things like that. And then communication. So we're now getting into that tier 3 where I don't want them holding the phone, updating parents or updating providers until they've gotten to a point where they've mastered skills in tier 1 and tier 2. They shouldn't be providing communication if they don't have that foundation of tier 1 and tier 2 skills. So now they're holding the phone. Now they're starting to update parents. Now they're starting to be a part of the update or communication with providers. Moving on into tier 4, this is the place in orientation where time management should feel good. Work, not total workload management, but that they know how to do a care. They know all of the things that go into giving medications, feeding babies, things like that. So this is where admissions, discharges, transfers come in. So this is really when we do start to, like my phrase for you guys usually in check-ins is like, go see the things, go see the experiences, because it's not every day that you're going to have an admission or a discharge in your assignment. So have your preceptors do your care. You go see that admission, you go see the discharge, even if it's in another neighborhood. I do tell them, I look to you guys, you're the experts on if it's an appropriate experience for you to witness. For them to be a part of. If it's something where you're like, I'm not sure, maybe this family needs a little TLC and this isn't appropriate, or there's a lot of people in the room, then I tell them to look to you guys on the appropriateness of that situation. And then finally, tier 5. So this is workload management. So this is handling the assignment in whole. I will say that, new grads, even some experienced nurses, depending on where they came from, like new to specialty nurses, it takes some time for them to truly have full workload management, but really looking at this place in orientation that they know what resources to go to. They're asking the questions. They're not just like sitting with themselves trying to manage it all. That when they come off orientation, they're going to get behind. They're going to have crazy shifts where, everything feels a little overwhelming. They need support, but they're looking to you for support. They're asking other resources for support. They know who to go to. They're delegating the appropriate task to the appropriate resource. So that's really where we work on those skills in tier 5. Does anybody have questions related to TSAM or the objectives that fall within any of the tiers 1 through 5, or any experiences that you've had with orientees where maybe this has been challenging, it's been helpful? Okay, wonderful. So really going just into why TSAM. So new team or new hires, they do struggle, like we said, with workload, prioritization, organization, or have less hands-on experience. At times, I think that came from when we were in a COVID world. There just wasn't as much clinical experience coming straight out of nursing school, especially. And coming from other specialties, maybe, some habits that just aren't going to help them be successful in an ICU, very busy unit environment. Um, so really this TSAM model again allows them to have hands in every assignment that you guys have responsibility over, but they're only putting on their plate what they can manage, and they're only adding to their plate when there's room. We're not just dogpiling onto skills when they're not ready to add onto that plate and into that bucket. This is where, if you're starting to feel like you're not able to move into different tiers, you're struggling to get them into a place where they're able to, um, you know, move into tier 2, we're still having things lingering from tier 1 or tier 3 to tier 2 kind of a thing. That's a great thing to escalate to us, because those are concerns that we're not able to build onto that strong foundation. If we're not creating a strong foundation, then we really need to look at why we're not accomplishing things in tier 2, tier 3, wherever we're at. So the goal is to be, have better prepared new grads, new to specialty nurses coming off orientation, and to really ease that transition to independence. Like I said, they're still going to need support with time management. They're still going to need support with delegation, and prioritization, as well, but that they're practicing that before they come off orientation. They know who to ask the questions to. They know how to, maybe they don't know what to delegate, but they know they need to delegate something and they're asking for help. Healthy habits, so just kind of giving you guys an overview of things that we do talk to them about in their first class day and their first small group. So in their first small group that we host with them, we really talk to them about healthy habits that are going to set them up for being successful in things like hands-on care, time management, things that again we don't expect them to be proficient in right off the bat, but are going to help. These healthy habits are going to help create strong, um, resourceful new grads that come off of orientation. So we like to share these with you guys so that you can also implement it into your expectations, because you guys are going to be the ones that are setting those expectations in real time at the bedside. So arriving to work on time and appropriately, we do have Saj checks everybody's time cards, and she will escalate to us if she sees that people are, routinely showing up late to work. But really just want you guys to also escalate to us in real time, because she has so many time cards to go to. If you're starting to see that this is a consistent routine, or something that is happening often with your orientee, please escalate to us so that we can look at their time cards sooner rather than later. Safety checks is a big thing that right off the bat we give them the education and a resource in their first small group. We tell them that right after they get the education and demo with us, that it is their responsibility to handle the safety checks in the room. We want them proactively doing those safety checks, that they're not just looking at the ambu bag, or, like looking at their suction from a distance, that they're really like lifting the ambu bag off of the arm, that they're looking at the rescue FiO2, that they're getting down and making sure that their suction is, correct between 80 to 100. Um, and that they're talking these things out with you as well, because you may be seeing them lift the bag and kneel down and do all those things, but what are they looking for? Do they know that the parameters are 80 to 100? Do they know that the rescue FiO2 needs to be 10% above the baseline of the baby's, what the baby's requiring? So we do tell them, have, talk through what you're checking, what you're doing. But if you're seeing that they're not doing that, I do want you guys to say, can you talk through with me the things that you're checking, just so I know that, ensuring understanding, closing the loop, that you know what you're checking and that it's appropriate. Ensuring that they are instilling organized habits and expectations. So tidy rooms, clean and tidy rooms and tidy babies. I feel like we get into this habit sometimes of I think when you're new, that you're checking the boxes, you're trying to get through, you're trying to be on time for things, and then things like cleanliness or being tidy kind of gets like lost at the wayside, and that's something that parents really notice. So really making sure that that's a part of their time management, and that you guys are setting that expectation for them, that the baby looks tidy, the room looks clean, there's not linens thrown all over the place when they're leaving for their next care. Bedside cart is, like clean and organized as well. This is something that means a lot to parents and something that should be a part of their foundation. Restock your cart for your next shift. Please be nice to your next nurses. I know that all of you guys are wonderful in doing that, but make sure that that's a part of their marrow as well. Um, Baby always needs to be nested, developmentally appropriate, and tidy. Going in early and on time for hands-on care. So on time is early. Really, that baby should be fed at their hands-on care time. So making sure that they're going in as early as they need to, even if it means 30 minutes. I know that that's a lot, but when they're first starting, it may be appropriate. Okay, so just kind of feeling out what they need and going from there. Organized hands-on care, the flow, like making sure that the flow makes sense, it works head to toe, clean to dirty, that it makes sense in their mind. If you're feeling like you're having time management concerns, one of the first things that I'm going to ask you guys is what's going on in the room? Like, what are you seeing them doing? Are they popping out of the room multiple times? Are they, are they going from dirty to clean, clean to dirty, having to change their gloves, do hand sand, do hand washes when that's unnecessary? There's a flow that can kind of help with that. Those are the things I'm going to ask you. So, really, if you're feeling like time management concerns are coming up as something, just observing what's going on in the room and then talking with me about that, and we can help implement things from there. Okay. So we have Mara on. Good morning, Mara.
Morning, you guys. What's up?
So I'm gonna jump. I have like a couple things that we can hit later, but I want to give the floor to Mara. So
Ah.
constructive feedback with Mara, with my favorite picture of her. So giving a quick overview, we provide opportunities for our fellowship team members to have small groups with Mara. It's something that we implemented a couple years ago, I'd say, but it has
Mhm.
been wonderful, something that we get really positive feedback from in their evals. They love time with Mara. Um, but really, talking with her through, because it's a very tough time when you're on orientation. You're under a microscope. You feel like there's nothing that you can do that is right. You're hearing different, opinions from different preceptors. So it's tough. So I feel like a lot of times a common theme can just be, that feedback is hard. And we really wanted to also give time for our preceptors to hear from Mara on how to have tough conversations, where feedback falls into all of it, and what it feels like to be new and kind of their view of things. So I will give the floor to Mara for her little spiel.
Awesome. Thank you. Yeah. A
Thanks,
lot of
Mara.
people, I feel like they end up feeling kind of like freshmen again. And like you all are like the seniors and they don't know where to like sit at lunch. And like, right. So, um, this is something we talk about a lot, like giving constructive feedback and having hard conversations. And there are like zero people who are fantastic at receiving feedback, including my own self. Like if my boss says I need to talk to you about something, I don't stay calm, certainly, right? I get defensive and I get ready to be fired. Right. Carry on. Do I have slides here, Carly? Or am I just talking? Oh, I can't hear you. Sorry.
Sorry, I have had myself muted. I think last time you pulled up your own slides. I just
Okay,
gotta make sure.
I don't have any today, so I'll just like I didn't I'm sorry. I
Okay.
thought you guys
No,
had
that's
them. But
okay.
so I think the most important part of this, and I know you guys have heard me talk about this before, is just knowing that that power dynamic, that you actually hold the power in that power dynamic when it comes to preceptor and orientee. So just knowing that you kind of set the tone. And I think you can do a lot with that in saying, like, hey, I'm about to have a very vulnerable conversation where I share some things with you. This isn't an easy thing to do, so I really appreciate you sitting here with me and really acknowledging that it is a hard conversation and that these are not easy for anybody and that you're going to take a deep breath together and figure out how to do this. So knowing what can ground your body is really, really important. So I'm going to give you a couple of ideas. One is like ice water or ice, candy, um, something that smells really good, like an essential oil. And I will tell you that the mental health team has put up grounding boxes in every nurse's station now. So again, if you're about to go have a hard conversation, give feedback, maybe grab a couple of the things from that grounding box. And just knowing that you generally go into something like fight, flight, or freeze, right? Even though it feels really dramatic to go into that, attachment is a really important survival piece. So you do go into that fight, flight, or freeze. So knowing which one you are more likely to go into, right? Do you want to get out of there? Do you want to fight someone who gives you feedback, or you just shut down? And really acknowledging that that's what your personality does for you. So doing the grounding before, during, and after is going to be extremely helpful. Do you have anything to add? Okay, that's great. Any questions on that one? You go get ready, please. I don't want to talk about it. Any questions while I parent?
Is that all you had, Mara? Oh, You're muted.
That's the main kind of crux of what I wanted to say. So thank you so
Wonderful.
much. I
Thank you
appreciate
so
it.
much.
All
Have
right.
a
Bye
good
bye.
day. Bye. Okay, guys. Awesome. So, real again, just wanted to give you some time with Mara on. I understand that what we're asking and having tough conversations can be rough, but we're also here for you in that. You do not need to be alone in that. We want to be a part of helping you either prep to give the feedback if you feel comfortable, or giving that feedback together as a team, or us giving the feedback. And we talk through those things and how it looks. And also just you guys getting a perspective of how they feel on some of certain things and being new, which I feel like a lot of you guys probably remember the feelings of being new. Um, so just really wanted to give you guys that time with Mara. But let me go back to where we were at. Um, we may go, oh, I feel like 8:45, I feel like I have plenty of time. If we go over our time today, please feel like you can log off. I want to respect everybody's time. I am recording this meeting so we can send you guys the recording if you missed just the end of it. But I did add some content just with covering the central line competency because we've gotten some really great questions and I just wanted to cover that content in detail. Um, Okay, so central line changes. So a lot of you guys know or have been a part of the central line change competency that we host on fellowship. And then we also host in an off orientation competency to make sure that best practice is still being utilized at bedside. To give you guys an overview, we implemented this competency. I implemented, I think, like 6 months after I had been in this role because I was getting a lot of feedback that, one, we didn't have any kind of skill station or skill support with central lines. And I wanted to implement something like that. But we also were getting feedback that people were doing things a lot of different ways, which, nurse autonomy, there's, 100 different ways to do something right, but that there were concerns with CLABSI, there were concerns with central line safety altogether. So that's really why we implemented this as a support. And we're just going to go over how we support the orientees through orientation and our plans moving forward to even provide this education to the unit. So central line changes. So we have these central line practice forms. They look just like this. This is just one of the pages. This is for central line 3, just so you guys can see all the objectives written out nicely. The goal is for the orientees to have at least 5 central lines with a preceptor scoring them. So right here, sorry, I don't have the headers up here, but right here, this darker purple, this is where the preceptors score. And then we always care about, how they see themselves and their self-awareness of how they're doing. So this light purple area is where the orientees will score themselves. You'll score them on a scoring scale of 1 to 4, 1 needing it's like total intense guidance of a certain objective, and 4 being completely independent. Um, I do ask that within the certain objectives, which we are going to go through together in the next couple of slides, but if you have an orientee that is scoring, I'm sorry, this is incorrect here, but if they're scoring between 4 or 5 or 3 or 4, like they are still, if they're needing anything less than a score of 4, that you guys are putting a comment in this little commentary box over here in the blue area. Just because we aren't there in real time, I'll often have people score somebody like a 1 to a 3 on a certain objective, but there's no comment there. And we don't know what portion of that objective they didn't score well on. So if they, scored a 2 on prepping for the central line because they didn't wipe down their environment, there's so many objectives that fall into that first tier. So just putting in a comment in this blue section, did not clean environment prior to putting out sterile field. Just so because you're there at real time and we are not, we have an understanding of why they didn't score a score of 4. The ultimate goal is for them to be scoring between a 4 to a 5. I'm sorry, a 3 to a 4, needing minimal to total guidance, or total independence for their 5th line change. So this is for basic lines, and this is across the board. All of our central line competencies will be a PIC line, TPN and lipids with a med line, and it'll be a Monday or Thursday night, so they need to know how to change the blue clave. Sorry, that was a little confusing with that first part. So again, just to reiterate, the goal is that they are scoring between 3 to 4 by their 5th line change. So that's right before they're about to take their central line competency on orientation. And then we already went over that. Any questions about the form itself before I go over the objectives, or like what the goal is for them to score? So prepping for sterile line change. So that's that first objective that's up here in that first box. So this is things like collection of items, so that they've collected the correct number of pumps. They've collected the correct fluid, along with checking it appropriately, whether that's with the TPN sheet or with your orders and Epic, and things like that. Common things with the collection of materials that we see is making sure that they know what is the correct lipid tubing to grab. So, and that's down here in this little resource that's on Teams. So the less than 0.5 and intralipids is going to be our small filter, the small blue lipid filter. And then anything that's greater than 0.5, SMOF or Omega Van, they need to have the large lipid filter and then the 2 ml straight tubing. Um, Other thing that we make sure that they are aware of, it's not necessarily wrong, but we are teaching that they need to use clean flushes, and something that, like, from education, we're encouraging to the entire unit. Using the sterile flushes, that sterile flush is just so large and they are expensive. It's appropriate to use a clean flush. We'd like to save those sterile flushes for, pick insertion related needs or central line related needs. Um, for changing lines every 24 hours, it's appropriate to use a clean flush. Um, Not the sterile flushes. Along with that is cleaning the environment and surface. So making sure they're using Oxivir, they're cleaning their entire bedside cart and pumps, whatever, and that they know that the dwell time is at least a minute, so that they're giving that proper dwell time to let it, let that agent properly kill the bacteria on the surface. And then dropping the materials onto the sterile field. So we understand things happen at bedside. You guys know best. Things come off sterile fields, sterility gets broken. We understand that in central line competency, it happens. We just ask them to declare that they broke sterility. My blue clave fell off of my sterile field. I need to get a new one. So declaring when sterility is broken and the appropriate response of what they would do at bedside if that sterility was broken. Um, Next objective, connection of materials. So using a resource. So if your orientees aren't using a resource, especially when they're first starting, this is like step number one that I would make sure that you're instilling, or making sure that they're instilling for themselves. I have this pick line resource put on here from the Teams resource that we have. If the Teams resource doesn't work, creating their own, making one that's colorful, color coded, pretty, whatever works best for their brain, but they need to have some kind of resource taped up and in the room with them while they're changing the line. Again, clean flush, not sterile flush. Connection of material, making sure that, a nice little visual aid here, that they know that the two-way needs to go if we're going bag to baby. Two-way comes first from the bags and syringes, and then the three-way. The reason for this is making sure that we have the correct med math for that med line. If we have the three-way that's up closer, the med line is further from baby, and that med math of 0.8 to 1 ml does not work. So just making sure that they're aware that it needs to be we're going bag to baby. Again, it's two-way to three-way to baby. And that's a nice little visual aid here. Okay. Knowing how to attach and prime the blue clave. I feel like this is something that comes up often, and I know that it can be tough if they're not working a Monday or Thursday night, they don't get that practice, but we do cover this in skill stations with them. But a lot of times in the competency, we'll have people, they have the blue clave ready, and it's on the field, but they don't attach it to the line and they think that it gets attached later. So just so that you're implementing practice for them of how to prime a line that needs a blue clave change. Um, Maintain sterility. Again, if sterility is broken, they just call it out with the appropriate corrections. And then also doing a nice double check for themselves before they even think about connecting line to fluid, that all clamps are clamped prior to even beginning the connection of the line to fluid and starting priming. Any questions on these first two objectives, especially or like any input or feedback from my night shift people who are on? Okay, wonderful. So then connection to fluid. So the really big thing here is there are multiple ways to connect the line to the fluid. We are working on standardizing how we are changing central lines, and something that we're doing with unit competency this year. But really, our big things with the competency right now is that they are just maintaining sterility. And I think this is the thing that confuses most people, especially when they come from the adult world, where sterility is a totally different animal than, what we're looking at here. But really, as long as they have one clean hand that's handling the central line and they have one dirty hand that is handling their bags and their syringes. A lot of people have asked me, because it's something that I have been implementing in skill stations and that I used to teach my orientees, was a 4x4 method. I would just drop 4x4s onto my sterile field, and I would have my orientees use those 4x4s as grabbers. So they would use a 4x4 to grab their fluid bags, that to grab their syringes, so that it just really helped them with, because it would blow their mind that like one hand had to be clean, one hand had to be dirty. And that was my solution of like, okay, use these 4x4s as maintaining your sterility. And that was just something that I implemented. Not something that you need to teach. Both of these methods are correct. But I just wanted to add that into, that is something that I've been adding to the central line skill stations, just to help with those that have really struggled with the clean hand and dirty hand. Um, we do teach that all fluid needs to be connected before priming is started. Again, it's not wrong if they connect TPN, prime it, then connect lipids, then prime it. But with newer nurses, novice nurses, there's more opportunity for them to break sterility and for them to manipulate their line and break the sterility of their line. It is safer and evidence-based supported that everything is connected first. Your TPN's connected, your syringes are connected, your flush is connected, and then you start to prime everything. Um, Again, both ways aren't wrong, but we do get into a little bit of a sticky area when, if they do connect and then prime, that if they break sterility, then that way is no longer right. They've broken sterility of the line. So I just also wanted you guys to kind of know that form of things, that we are teaching them that everything needs to be connected first and then priming starts. The best way to teach a novice nurse, and that makes the most sense in their mind to have like a start to finish, really is to first connect the TPN, then connect your lipids, then connect your flush to your extra port. You'll prime the extra port, remove that flush, and connect to Medline. Then you'll flush through your Medline and leave that flush on the Medline. So the reason you do extra port to Medline is because it limits the number of times that you're entering the line. So flush extra port, connect to Medline, flush the Medline. After you flush the med line, then you can prime through your lipids and your TPN. Again, this is not like, doesn't need to be Bible. This doesn't need to be, but as long as everything is flushed through, that's the most crucial point. I'm just telling you guys what works best for the novice brain in using these steps of TPN to flush, and then just going back through, like following your trail back. Does anybody have questions or even feedback on the connection of line to fluid? You know, it's kind of like a lot to talk through and visualize, but like more education is to come for the unit. Priming fluid, really just the big things here that we're looking for are that no bubbles are left behind with minimal fluid lost. There is a lot of times where we have people like really trying to catch up with bubbles, really trying to, manipulate the line and get all of the bubbles out, but they've lost like an extensive amount, a very large amount of fluid, an excess amount of fluid, I should say. And really, we, try to educate them on like TPN, lipids. Those aren't things that we can just order. So we really have to make sure that very minimal fluid is lost in the removing of bubbles. Making sure that you're teaching them the Laurel locks, that they need to be inverted and flicked as fluid is going through. I know that a lot of people say that like if fluid just goes through appropriately, there's no bubbles that end up being found in their line. Per manufacturer, bubbles are hidden and get lost in these Laurel locks if they are not inverted properly and flicked to make sure that there are no bubbles that are left behind in those Laurel locks. Inversion of the clear link filter, so a lot of people call it the tampon filter, making sure that it is inverted, so clamp side down, and fluid primes through as you invert, and the clamp is clamp side down. Again, per manufacturer, this is how the filter collects bubbles and properly eliminates them and is used to its best function. And then a lot of people don't know this, but the small lipid filter, the small blue lipid filter, it does have an arrow on it. It shows you that the arrow needs to be pointed up. So as you're priming through your lipid filter, just making sure that arrow is pointed up as lipids are going through the filter. And really the big thing that everything is primed through. We do not like ask people to go through the central line competency for many things. And one of them is if they leave a part of the line not primed through, and that is a huge safety risk for the baby. So that definitely needs to be something that is double, triple checked to make sure that the baby is not getting a huge air embolus and that everything is primed through properly. Any questions on connection of line to fluid or priming? Connection of line to fluid. So really setting your orientee up for success. I feel like this is the part of the line change that is very stressful for new team members and with learning central line changes. So I took a picture here. I think really setting them up for success and organization on even things down to, here's your old central line here connected to baby. It's on one side of the baby. Your new line is on another side of the baby. So making sure everything is organized. The portholes on the side of the bed here, you can't really see them, but like where your lines and your cords come through. I even would have my orientees old line went in the bottom port and then the new line went into the top port, vice versa, whatever works for their brain, but just making sure again there's a major differential of which line is which. Because one of the biggest things that we got feedback on with starting this competency is that people in the heat of the moment would start disconnecting a line once everything was done and new line was connected, and they ended up starting to disconnect the line that was connected to baby. And really in the disorganization of it all, this could have been avoided of making sure that the bed was organized, one line's on one side, one line's on another, just making sure that they have awareness of what's going on. Enough space for your 4x4s with alcohol. So you guys know how to set up your nice little sterile field. This pick is, had a nice long neck here. So had plenty of room for one side of the 4x4 to be on, for your old line to be on one side of the 4x4, and then you've got your new line here on this 4x4 with your alcohols on this side. If you're working with a pick with a shorter neck, or you don't have as much space, getting a whole other 4x4. The biggest thing that I like to avoid and I like just try to implement with my orientees or with the new team members is that most of our picks are in our feet, right? The bottom of the bed is a very dirty area. If this pick for some reason drops during mid-central line change, I don't want this dropping on the bottom of the bed or on a place where we change diapers, we put wipes, it's a dirty area. So it needs to fall onto something that's clean. So making sure that if, this setup doesn't work, that you have something that's underneath that central line. Even for this baby was kind of at the bottom of the bed when I first started this demo, but like I moved the baby up. There were times I moved the baby up as far as I needed to, even angled the baby, getting the baby, as comfortable and kind of out of the way of that sterile field just for the moment of the central line change. As soon as that central line change is over, you can move baby back in their little nesty or wherever they're at, to be, in a more appropriate position. Um, Save space for lines. So double check that all is ready, like have them do a little pause for themselves. Okay, is everything out and ready to go? Oh, one thing I did want to say, I feel like some people will have their orientees leave their new central line in a 2x2. That's totally fine if that's how you want to teach them, but just make sure that they set themselves up for success, that they like open that 2x2. It's not like twisted in on itself or even taped before they put their sterile gloves on, and that it's easy for them to pick up that central line and have it ready to be connected to their pick line. I feel like a lot of people will like struggle with the dexterity of staying sterile and trying to get that pick out of the 2x2. So that's why I just have them put the new pick right onto but it needs to be on the clean side of your 4x4 with your alcohols. Okay. So we've double checked all is ready. We've taken our pause. The bed looks organized. They're set up for success. You're going to go ahead and, have them prep their sterile gloves, have them open, ready to go. And then they're going to go in and they're going to clamp their pick of their baby. They'll go back to their sterile gloves, put their gloves on. They'll grab that first alcohol to use as a grabber to hold the pick. They're going to grab that second alcohol and clean the outside connection of wherever they're disconnecting. So this is another piece that I feel like we get a lot of feedback on. So if you can see my little pointer here, if we're changing the 2x2, or I'm sorry, if we're changing the blue clave, that line change, then they need to be cleaning this portion here, not up here where the pick meets the old pick meets the blue clave. So making sure they're cleaning at the correct connection. So they're going to clean that outside connection for 15 seconds. The biggest thing also, they need to remove that alcohol from where they just cleaned and let it dry for 15 for it to properly dwell and kill the bacteria on the outside of that connection. They can go ahead and take that same alcohol that they just used, remove the pick, the old pick, and put that to the side. They're going to take that last alcohol, clean the exposed pick for 15 seconds, then let it dry for 15. Usually while I'm letting it dry for 15, I'm like telling them like, okay, go ahead and grab your new pick and have that ready to go. And then they're going to connect the new pick to their central line. They're going to go ahead, take like, that minute to be like, all right, everything's connected, go over to their pumps, switch their pumps over. Then they're going to make sure that they unclamp from bag to baby. So this is what's going to cause that positive flow of fluid from bag down to baby. There's no risk of backflow or negative pressure from the pick, because this can cause picks just to also not even backflow, but can be like irritating to the vessel or pick line itself. So making sure that you're going your bag is ready to go, started and run, the line is unclamped, and then last but not least, the baby is unclamped. Okay. With the cleaning, please make sure that they're looking at a clock and that they're not counting. Everybody's 15 seconds is different. Also make sure that they're instilling that 15-second dwell time. I think that that's also a common thing that we have to give feedback on, that they're not giving the 15-second dwell after the 15-second clean. I know that's a lot of steps. Again, I will send you guys this recording and the slides too, if that's helpful. But any questions or feedback on the connection of line to baby? Last but not least, like the hourly rounding and Clabsy bundles. So always handling the line with care and CLABSI in mind, so that they're not just, manipulating the line, even for, like a hands-on care or, just going in to check the line. They're always wearing gloves. They're never doing anything with bare hands. Blue claves, that they're aware that that's changed on Monday and Thursday nights. Heroes caps on all ports. No more than one extra port for emergencies. Really just like giving them that awareness that, I think that in an ICU environment, we're always like want to be prepared for the worst and make sure that we have enough ports. But extra ports leads to increased risk of infections. So knowing that you will always have only just one emergency port, but you can build off that emergency port if extra drips or anything is needed. Fluid lines, fluid bags, syringes, and the line are labeled. Assessing for the necessity of the central line. So I know that this isn't, like the top responsibility for the bedside nurse, but part of our responsibility is to see, like, are we at a place where we can pull this PIC line? Because at the, same time, increased days of central lines placed increase the risk for infection. This really is run by providers mostly, but it should be on our bucket of things to be aware of that, are we taking appropriate steps and opportunities to titrate fluid, get the central line out as soon as possible. And then also always assessing bags and syringes so they don't run dry on your shift. In that hourly check of checking your line for leakage and making sure everything's intact, your dressing looks clean, dry, and intact. You should also make sure that they are eyeballing their bags and their syringes so that they're not running dry. Okay. Um, Kind of getting back into like the feedback of things. So I know that we talked about this a little bit earlier, so I'll just go over this quickly. But feedback really needs, to be escalated to us as soon as possible. In real time, if you feel, comfortable, you feel, like it's an appropriate time to have that conversation. We love that. If you're feeling like it's something you need support on, we are here for you. Please just let us know as soon as possible so that we can talk about what those conversations look like prior to having check-ins, missing opportunities with them to talk about these things in real time. Okay, let's see. So things to escalate to us that if you're seeing these things at the bedside. So not following unit policies. So again, if you're seeing attendance issues, you're seeing that they're arriving late to work. Anytime after 7 a.m. or 7 p.m. is considered late. So if you're seeing those things, please let us know. Taking longer meal breaks than usual, not adhering to dress code, sleeping during night shift. I know that these things may sound bizarre, but things that have really happened and why they're a part of these slides, because they do happen. And I know that it can feel a little awkward to bring these things up, but definitely things that we need to escalate and that are not safe. Productive and proactive. So are they looking for things to do and to learn on the unit? There's so many things going on our unit at all times. Excessive scrolling on their phone is inappropriate, especially in their, first 12 to 16 weeks. This is where they should really just be wanting to be out and learning and seeing all the different kinds of experiences. Working on assignments during shifts. So they do get paid for assignments that they are completing on orientation. So this really should be time that they are handling these assignments outside of their shifts. This is time where we feel like, it's not time that we can get back on the unit. They can do the assignments at home. Lacking ability to retain basic info. So if you're needing to do multiple reminders of basic concepts after feedback is given or teaching strategy has even been changed, something to bring up to us. Struggling with basic workload management, unable to demonstrate comprehension of basic skills or concepts previously taught. So there are times where things are crazy, you guys have really busy shifts, and if you tell them something and maybe they don't, that they need like a little refresher on it, totally understand. But if there are basic concepts you're having to go over and over and remind them of, maybe we need to look into a different teaching strategy. Maybe we need to have them be reflecting in a journal and writing these things down that you're going over with them. There may be something that we can do to support why we're still seeing that you are needing to reiterate things multiple times. Lack of awareness on limitations. So if they don't seek guidance when needed, they need to be intensely prompted to ask questions. They've proven to not ask questions. They've just handled something. They come out and you find out about it later. That's like a major red flag and concern, and that's a like a blinding confidence that they didn't think or have a feeling like, oh, I should ask Michaela about this before I just do it, you know. Um, that's really being just like totally unaware of the resources that are available, and makes us very worried that if they have this built-in set of extra hands, extra eyes, and they're not utilizing them now, what's going to happen when they come off orientation? Loving the NICU. You know, the NICU is not for everybody. Like if you start to kind of get the feeling or the vibe that, you know, it's up to them to bring that up to us and what they share. But if there is like a feeling of, you know, the emotional like attachment to the babies, they're not like excited to be taking care of these, you know, really precious lives, and you're kind of getting kind of that apathetic nature towards like, you know, the patients, or, you know, the desire to be in the NICU, definitely something that we want to hear about from you. Um, we do have very new grad heavy cohorts. So a lot of times, a lot of these new grads, they don't even know what the NICU is. And it's a very unique and niche place to be here. And we totally understand it's not for everybody. We are very understanding and welcoming to these feelings if they bring them to us, and that we can get them shadow shifts on other units here. If they, you know, still feel like they maybe want to do pediatrics, or we want to keep them within a Nova, especially if they're a good team member. um we support that, and so does our leadership, and we can get them the supports they need to get them to a place that makes them happy and that fills their cup. um how do they react with the babies? I think kind of, you know, previous to the last objective, but like odd comments or apathy towards the patients, or how they react to families that need a little TLC. Like it's really inappropriate for you to be hearing a new team member saying like, well, this family's a lot, and like, well, this is just ridiculous, we're doing all of this. That is an inappropriate reaction, and something that like we do want to know is if that's being said, so that we can also implement like, you know, the appropriate uh supports that are needed there for that kind of reaction to things. Okay, just a couple more slides, guys. So health stream checklist is very, very long. Please just check in on this every week. I know that every shift is not really feasible with how busy the shifts can be sometimes, but at least every week that you're with your orientee, please just like put your eyes on this health stream checklist and see if there's anything that you can check off for them, so it's not left to the end. I'm sure some of you guys have been on the end of being the last preceptor and everything is left to you to check off, and it can be very frustrating. We usually put out a plea to all preceptors to check in on this before the end of orientation, but just, you know, getting eyes on things. If there are things at the end of their orientation, like PIC line placements, bereavement, you know, things that we don't see every single day, you can always go over resources with them, verbally go over the process of these, you know, these experiences that can be hard to experience, and that is sufficient enough to check off of their checklist. If you are a new team member, I'm sorry, a new preceptor, and you haven't accessed the checklist yet, when you sign on to HealthStream, it will say evaluate checklists on the right side over here under options. If you do not see this hyperlink, all of our new preceptors we put in access for before the orientees start, but sometimes some people will fall off oddly. If you do not see this hyperlink of evaluate checklists, please just let us know and we'll make sure that the access is correct. Precepting in the SBU. So if you are an SBU nurse, we will place you guys with your orientee in the SBU. We try and do no more than like 5 to a max of 7 shifts in the SBU. We try not to go over that, but you know, Vivian, you can see here, she's an SBU nurse, so we like put actual SBU shifts with her her orientee Sophia for these nights. If they don't have any primary preceptors that are SBU nurses, we just put them with fill-ins on certain shifts. Um, Rules and expectations, though, for SBU are different. It is not like our other ICU units where orientees can, you know, like exercise a little bit more independence. Orientees should not be alone in the SBU. That being said, there still are responsibilities and expectations that can fall on them as far as making sure that they're getting up and saying, like, okay, I'd like to go in and start the cares. You know, grabbing all the materials that they need, knowing what medications or what milk, what, you know, meds they need for that hands-on care, that's all being grabbed. Those are all things that they can still exercise. I don't want them to just think like, oh, this is a shadow shift, because that's just a missed opportunity for them to practice some workload management. Um, Answering alarms, never alone. They should still have that reaction of, this is my patient, my responsibility. But they should be hot on your heels and right behind you, if not in front of you. They may not be leading what's going on and helping the baby recover, but that they are like quick to respond to those alarms, and that you're not needing to like really prompt of like, this is our baby, we need to get in there. Please no inline suction on IVH babies. There is a practice doll in the, I believe last time I checked it was in the Meadow, but there's an intubated doll with inline suction that you can practice with them before they're practicing on a real baby. But please no inline suction at all with any babies that are on IVH bundle. Please avoid heel sticks on babies that are less than 28 weeks. This is just not an appropriate, you know, time for them to be practicing heel sticks. We've had some situations where babies have gotten really bruised, sometimes of no fault of the orientee, but just not like a baby that we want them to be practicing heel sticks on. Please reach out if you precept in the SBU and you haven't taken the SBU class. This just may have been an oversight from the unit supervisors. If you, like, especially if you haven't taken the class, you don't feel comfortable. We don't want to put you in an uncomfortable situation of no less precepting in the SBU. Really quick, also, just as kind of like a nice little example, if you guys tell us that you want specific assignments, we have started coding assignments like this. You can see with Karina, with some fill-in preceptors, or with Colleen, they were requesting NAVA or NIPIV central lines, 3 baby assignments. If you guys come to us and ask, we will put this into their schedule for unit supervisors to then communicate to the rest of the unit. Okay. So please let us know. I feel like this method has really helped with getting the assignments that preceptors and orientees want. Preceptor education. So if you are interested in additional supports for preceptor education, we do offer, we've revamped the preceptor education through ANOVA. Level 1 is for all new preceptors. This is the foundation of precepting. It's 2 contact hours and it's via HealthStream. So this is going to be equivalent to the level 1 and 2 training that was previously offered. But this is going to allow you to meet those advanced requirements needed for RN2 or RN3 and RN3. Then you move on to the level 2 intermediate precepting. So these are for people who have been precepting for at least 6 months. And you must take the level 1 class first. This is the in-person portion of the preceptor education, but you will register in HealthStream if you are interested. This will be required if you are applying for your RN4. In 2026. Everything that's previous to this, like, allows you to apply this to your advance for RN4, but in 2026, if you're reapplying, you will need to take the level 2. Level 3, that's experience precepting. So that is greater than a year of precepting experience. Again, you must take level 1 and level 2. This is via HealthStream. You will register on HealthStream and continue the education on HealthStream. This is coming soon. This hasn't been released yet, but this is going to be required for RN5 if you're applying in 2026. So again, I will send you guys these slides so you don't have to memorize all that, but just a revamping of education for the next couple of years and what that looks like, and kind of just going from there. Any questions on the preceptor education changes? Then we already did our feedback with Laura. Okay, awesome. Guys, I'm so sorry. I went over 15 minutes. I am glad that you guys could stay on. I really appreciate it. If you guys need anything, we are here for you. I will put an hour and 15 minutes onto your guys' time card and send that to Saj. Our June fellowship starts next week. Thank you guys so much for your support with that. If you guys have any questions, concerns, anything, we are here for you. Anything I can do for you guys before we log off? All right, guys, thank you for sticking with me and I appreciate it. I'll talk to you guys soon.
Thank you.
Bye, guys.